Welcome back to the Principles of Global Health Equity. Today you're going to be learning about the social determinants of health. Dr. Luke Messac, who's an adjunct faculty here at the University of Global Health Equity, as well as an emergency room physician and a historian. He's also co-author on the seminal global health textbook with Dr. Paul Farmer, the Reimagining Global Health Delivery. So he's going to be teaching you about the social determinants of health.
My name is Dr. Luke Messac. I'm really excited to be joining you today. I'm calling from Providence, Rhode Island. I really wish I could be there in person, but they're not letting Americans do too much traveling these days, given how poorly we're controlling COVID over here. So thanks for letting me join you over Zoom. To tell you a bit about myself, I'm an emergency medicine doctor in my residency training at Rhode Island Hospital in Providence, Rhode Island. That's affiliated with Brown University. And I previously got my training in medicine and history of science at University of Pennsylvania. And I've been affiliated with UGHE and with Partners in Health for many years, and I'm very excited to be helping with this course, and looking forward to meeting you all hopefully in person someday soon. So we're going to start today with the social determinants of health. It's an important concept. It's a foundational concept in your course and your studies, and I think it has a lot of relevance to what's going on in the world today. I'll start with a story from a few years ago, a story from Malawi, where I was conducting my fieldwork for my doctoral studies. And there I met a man named Jacob. He was working at a mission doing construction work. And in the course of digging a hole, he had a rock fall on his leg. And it broke his femur in half. And it was a pretty painful injury. He went into a nearby district hospital where he was prescribed acetaminophen for pain. He received it in the clinic, and he was sent home with acetaminophen. And both in the hospital and at home, he was in a lot of pain, pretty excruciating pain. And I was interested in this because when we see this in the United States, we often prescribe opiates. And we certainly give them in the emergency department for pain relief. So I was interested to see the difference between the way we prescribe in the United States and the way I saw my Malawian colleagues practice in Malawi. And, part of the reason why he was only prescribed acetaminophen, I came to realize, was that while in the United States we have a problem with overprescription of opiate pain relief, in Malawi and many countries in the global south, there's actually it's actually very difficult to get a prescription for opiates, even for things like long bone fractures, even for things like terminal cancer and sickle cell crises. These things where in most of the medical literature, it's agreed that opiates do have a role. In much of the global south, you'll see that those are very difficult to come by. The second story comes from Philadelphia, where I did most of my training. And this is a story of a friend, actually. His name was Paul. And he was prescribed opiates by his primary care doctor in the late 1990s for chronic pain after a surgical procedure. So he ended up getting addicted to opiates, and over the course of the next 20 years, he was in and out of treatment for this addiction. And sadly, in 2017, he was found dead from a fentanyl overdose, something that was afflicting far too many people in Philadelphia while I was there, and continues to do so. So we see here two problems. One, a person in pain who may merit opiate pain relief, particularly in the acute setting, and another, someone who was prescribed opiates who probably shouldn't have and ended up addicted and dying from his addiction. So one thing to keep in mind when we're talking about these two different settings is that they're not the same medical settings, they're not the same social settings, they're not the same political settings. And that's brought home by the fact that the United States consumes 67,000 times more morphine per capita than Malawi. And this is not an expensive drug. This is a drug that costs a few cents for a pill to produce. So it's not just a matter of Malawi being a poorer country than the United States. There's something else. There's something else going on. You'll see this in this graph as well. This is morphine equivalents, essentially, the amount of morphine or opiates that are prescribed per person in different regions of the world. And you'll see that the green, 2007 to 2009, the more recent figure in this graph, shows a huge disparity in different regions of the world. So in North America, you see greater than 25,000 units. Units aren't that important, but greater than 25,000 units per person per day, and then, or per million inhabitants per day. And then in Europe, much lower. And then if you go down to Africa and South Asia, far, far lower. And in this graph, the UN, which released this report, says that 200 is the bare minimum you would want. And so you see that Africa and Asia and Central America are well below the minimum, whereas the United States and North America is far above it. And understanding how this disparity happened, why is it that Paul died of an opiate overdose and Jacob couldn't get the pain relief he needed, asks us to look at history. Where do opiates come from? Well, they come from the opium poppy, which is produced in fields in a few places in the world, largely in the Middle East and South Asia. Here's a picture from Turkey from the 1950s. And the production and distribution of opiates is a historical question, and one that I became interested in, and one that really raises this question of the social determinants of health. How do history and economics and politics in culture influence the medical care and the medical outcomes in different populations, in different peoples, in different countries? And so we'll come back to this question, more specifically later. But the social determinants of health is often thought of using these concentric circles. In this case, we see here that biological is the smallest circle. That is, it is the most immediate cause of medical problems, right? You have a biological mechanism. In the case of Jacob being in pain, his nociceptors were flooded. At the time of his injury, he was in acute pain. Whereas Paul, his mu opioid receptors were flooded, and he went into respiratory depression and died of respiratory failure, right? Those are the biological mechanisms of pain and respiratory failure, respectively. But that's not the only reason why they died, or why Paul died and why Jacob was in pain, right? You have behavioral, which is the next concentric circle, the next level of analysis. So the behaviors in question, right? Jacob's clinical officer did not prescribe him opiates. Why was that? Well, perhaps it was because at many medical training institutions in Africa and in South Asia, as opposed to the United States, people are taught to fear opiate prescriptions, to say that those will inevitably result in addiction. Whereas in the United States, for a long time, people were taught, my colleagues were taught, to prescribe opiates quite liberally, too liberally. So those are the behaviors that might impact the biological mechanisms. Then there is the societal level, right? So what are the other mechanisms that can affect behavior? So in the case of the opiates that we were talking about, one of the main mechanisms that led to overprescription of opiates in the United States was a huge campaign by a pharmaceutical company named Purdue that produced a lot of the opiates that were used in the United States. And this huge campaign focused on doctors and told doctors, don't you worry, the opiates we produce do not produce addiction, do not cause addiction. And throughout the 1990s and the early 2000s, they published these advertisements in medical journals. They paid doctors to make these statements. And so in many senses, American physicians let their guard down and they started prescribing opiates much more freely in a way that did produce addiction and overdoses that we're still dealing with today. So we can look at the behaviors of doctors, but you also have to look beyond that to the factors that influence the behaviors of doctors. And that is the economic interests of this specific company, Purdue, had a large role. And then structural, right? Structural is perhaps the largest bucket, the most fundamental of causes, right? So if you look at why Jacob was in pain and why Paul died, structural causes might include something like the for-profit nature of healthcare in the United States, right? Why did Purdue pay all these doctors and run all these advertisements? Well, they could make money selling to hospitals, and that is, we live in a capitalist society. People make money selling drugs. People can make a lot of money selling drugs in the United States, where there's very little price control on the private market. So the structural cause of Paul's overdose might include in the analysis the profit motive itself. So if you want to look at the social determinants of health, and we'll get into more of the definitions, you have to look not only at the biological cause, you have to look at the behavioral, the societal, and the structural causes of illness and suffering. So, these are some of the things that we want to talk about in the social determinants of health, is not only what it is, but also what it isn't. The social determinants of health asks us to look beyond the strictly biological causes. So oftentimes in medicine and public health, you'll hear about magic bullets, these things that are going to solve everything at a stroke. And these are very tempting. They're very nice to think about, in that maybe we can just come up with a cure, a simple fix, a magic bullet that will solve the problem once and for all. And so we see this sometimes in claims that we're going to fix all disease with a medical breakthrough. And you saw this when the Facebook founder, Mark Zuckerberg, and his wife, Priscilla Chan, she's a pediatrician, they donated a few $1 billion to this effort to cure, prevent, and manage all disease. That was their goal. And how they were going to do this was investment in research into artificial intelligence and blood monitoring. And while their goal is laudable, the mechanism by which they wanted to solve this problem, to cure, prevent, and manage all disease, was interesting, in that they saw artificial intelligence as this, perhaps this magic bullet that would fix everything. So why do we have reason to question, goals such as this? Not to cast aspersions on people who want to cure all disease. I would love to cure all disease, but why do we look at these singular tools when the history of medicine tells us that something else might be going on? And I say that because the right side of this graph, you'll see Thomas McCune. He was a researcher who found out that through his studies that tuberculosis mortality had been going down for decades, indeed for more than a century, when he did his research. And he was interested in why. And what he found was that before antibiotics had been discovered for tuberculosis, before 1947, when those antibiotics were discovered, most of the decline in tuberculosis mortality had already happened. And so something else, something other than medical therapy, was causing this. And he had many theories: nutrition, to some degree sanitation, he thought had a lot to do with it, economic growth generally. But what he did find out from this graph that you'll see is that because most of the decline had happened before antibiotics were discovered, we had to look beyond biology. We had to look beyond strictly medical interventions to find out what had helped bring tuberculosis mortality down so steeply. And in his case, he was looking at the United Kingdom. But we can see this in studies across the globe. So the second thing we want to look at is not only looking beyond medical interventions, but looking beyond biological causes in general. And so we see this in our propensity, our desire to find a medical cause of many things. So look at this Time magazine. It's a popular magazine in the United States, or used to be. They ran a cover in 2015 where they said that this baby could live to be 142 years old. The idea was that we all could live, or maybe our children could live to be 142. And what they were looking at was this study published in Nature, a very prominent scientific journal, that showed that mice that were fed rapamycin, this biochemical, would live twice as long, almost twice as long as regular mice that weren't fed rapamycin. And the mechanisms were postulated in this article. It suppresses the immune system. It inhibits mTOR. All these mechanisms were posited as to why, but most of the excitement was about the fact that if we were started to take this, maybe we could just put this in our food. Maybe we could just swallow a pill every day, and we too would live to be this old. And this is yet to be proven in humans, although it's generated much excitement. But at the same time, we know that there are huge disparities in life expectancy in the United States. In Philadelphia, where I lived for a long time, you'll see that in the northwest corner of the city, the life expectancy is 68 years. And in the southeast corner, where people are much wealthier, it's 88 years, 20 years difference in life expectancy. And it has nothing to do with rapamycin, or at least people aren't taking rapamycin in their daily diets in Southeast Philadelphia. There's something else going on, and it probably has to do with the wealth and inequalities that exist in the city. And the other thing we want to question when we talk about the social determinants of health is focusing strictly on the behavioral causes, right? Remember those concentric circles. The biological was the smallest, the behavioral was the second smallest, and then you had the societal and the structural were the most fundamental. But behavioral was only the, just next to biology in how immediate the cause was, but it wasn't one of the most fundamental. And so we look at public health and we see that there are many behavior change campaigns, right? Uganda had its abstinence, be faithful, use condom campaigns for HIV/AIDS. In the United States, a lot of the behavior change campaigns have to do with drug use. The United States government spent over $1 billion in the early 2000s on a campaign to get people to stop using drugs. And one of the interesting thing one of the interesting things that some of the subsequent studies have found was that people who saw these campaigns, like the poster you see here, that tried to get people to stop smoking marijuana, people who saw these campaigns were more likely to use drugs than people who didn't. So they seem to have the opposite effect from what people would want. So, that raises the question, well, what can we do if we want to change behavior? Maybe we have to look beyond, campaigns that encourage people with posters and with advertisements, and look to other causes of behavior, the societal and the structural, rather than just in trying to intervene directly on behavior. So the social determinants of health, again, differs from the standard biomedical or public health approach in that it tries to focus on the structural and social causes and not just the behavioral and biological causes. So we're going to talk about a few more terms here that I think will be important in your studies going forward. We're going to talk about biosocial approaches. And you'll hear this coming up all the time in the course. Biosocial, you'll read about biosocial approaches. And it's not a normal word that we hear every day, but what it means is that biological and medical processes are affected by history, by political economy, by culture. And so you can't really understand health and disease until you understand that the biological and the social are linked and therefore have to be studied together, right? You have to cross disciplinary boundaries. You have to understand history and anthropology and sociology and economics and politics if you're going to understand health and disease. So that requires you to understand upstream causes of illness, things like housing, things like employment, nutrition, education, public policy, fiscal policy, trade policy, if you're going to really get a handle on why people get sick and how they get better. So finally, we get to social determinants of health. This is defined in many ways, but there's a WHO commission in 2008 that said that the social determinants of health are essentially, it means the idea that disparate health outcomes, right, unequal health outcomes are caused by the unequal distribution of power, income, goods, and services, which result in differences in access to healthcare and education, differences in conditions of work and leisure, and differences in the features of homes and communities. It's also the idea that these differences, these unequal outcomes, these unequal distributions of power, income, goods, and services, they're not natural. They don't come from God. They don't come from natural law. They're the outcomes of policies and economic systems that are made by human societies. And therefore, they're subject, they can be changed by human intervention, right? We have the power to understand these causes. We have the power to intervene on these causes. So look at one of the most important initial studies of social determinants was by a British researcher named Michael Marmot. And he studied death rates from coronary artery disease, from heart disease, on British civil servants, so British public servants. And he looked at British men working in the public service by different grades of public service. So were they low level, were they medium level, or were they high level public servants? Were they administrators, like high level administrators? Were they professionals? Were they clericals? And he found that the death rates among the high level administrators, right, you'll see them in the white here on the second graph, was much lower than the mid-level professionals, which was in turn much lower than the clerical staff. right? So as you go down in grades, you go up in mortality. And he controlled for many other variables, obesity, lifestyle, um, pre-existing medical conditions. And he found that even with those controls, that the death rates were higher in the low grade staff, in the subordinate staff, as opposed to the bosses. And he thought that maybe it was the stress of being someone's employee rather than the boss, that led to these higher levels of mortality. So social determinants of health is interested in these individual level risk factors, such as income or grades of employment. And it tries to understand how those kinds of factors impact health outcomes, right? How does the level of employment, how does your position in your job impact your likelihood of dying from heart disease? So here's another example, this one from more recently, and this looks at infant mortality levels between countries. So you'll see that when you look at the line, the main part of the graph, that you'll see that infant mortality varies pretty widely between countries on this graph. From the left, we'll see Colombia, 20 per 100,000 or per 1,000 live births, resulting in mortality, and then Mozambique on the far right, greater than 120 per 1,000 live births. But look at within the country. So look at Mozambique. The low part of the line of the bar shows infant mortality among mothers who had a secondary education or higher. So if the mother had a secondary education or higher, infant mortality was, let's say, about 60 per 1,000 live births. And if it was, if the mother had no education, then it was much above 120. I can't see it because my own face is blocking the graph at this point, but it was much higher. So the idea was that even within a country, the level of education of the mother had a huge impact on whether that baby would live. Here's another graph. This is the Preston curve. It's named after a demographer named Samuel Preston, who created the graph. And this was created in the year 2000, but you can see this graph for different years. And it usually shows the same relationship, which is that as a country gets richer by GDP per capita, the life expectancy increases. But that relationship is interesting because it goes up very fast at the lower levels of income, right? And then eventually it kind of flattens out. And so the richest countries have a relatively little difference in life expectancy. And even within that graph, you'll see pretty interesting differences. So, Botswana has a relatively low life expectancy for its GDP per capita. Mexico has a relatively high life expectancy for its GDP per capita. Japan, a relatively high life expectancy for its GDP per capita. The USA, where I live, is a little lower than you'd expect for its GDP per capita. So there are other things going on there aside from the wealth determining, or the aggregate wealth of the nation determining how long people live. But there is this relationship, pretty statistically significant relationship between how long people live and where they're born, the country that they're born. This is another example of under 5 mortality rate per 1,000 live births and the level of household wealth within a country, right? So in Uganda, you see that the under 5 mortality rate for the poorest quintile of the population is almost twice as high as for the richest quintile of the population. This is another graph from Amartya Sen, one Nobel Prize winning economist, who showed that the likelihood that you would live to an old age was determined in part by race and ethnicity, and also where you live. So in China, the proportion of men surviving to their 65th year is about 70%. Whereas in Harlem, which is a neighborhood, a poor neighborhood in the United States, or used to be a poor neighborhood in the United States when this graph was made, the proportion of men surviving to their 65th year was 40%, right? So even though the United States is far richer than China on a per capita basis, in Harlem, death rates were much higher. So that tells you that there's important differences between countries, also important differences within countries. I also want to talk about social medicine. Social medicine is another form of studying differences in societies, differences in health outcomes within societies. And in social medicine, we're interested not just in individual categories like income and educational outcomes and how those affect health, but also in more structural causes, in how history and how social categories have impacted health outcomes. And a lot of these figures in social medicine end up interested in changing policies, interested in the actual role of political outcomes in determining health. So the father of social medicine is a doctor named Rudolf Virchow, and he was a German pathologist. He's responsible for the Virchow's triad that you often learn about in pathology, or you will learn about in pathology, and is famed as one of the fathers of cellular pathology. But he also is known as the father of social medicine. When he was a young man, probably not much older than many of you, he was sent on a mission by the Prussian government to study what was known as famine fever in one of the regions known as Upper Silesia, which is today in Poland. And he wrote a report that said that this outbreak was due not just to disease, but had been caused by the lack of political representation of the Upper Silesians in Parliament and the structure of taxation in Upper Silesia. He pointed to these political causes, and he said that if we wanted to solve this outbreak, that you needed to give more democratic representation to the people who were suffering. You needed to have progressive taxation to fund disease campaigns, things that actually the government was not too happy to hear when he sent his report in. But these were the things that he was focused on. Later in life, he would become involved in other political movements, and he himself would become a member of parliament later in life too. So goes to show you that doctors can have a very important impact on basic science while retaining a deep interest and passion for social medicine. Some other examples of similar life stories. Salvador Allende, who was a doctor in Chile, who became the president of Chile, who called for access to healthcare and helped pass one of the first universal healthcare programs in that country. Alfred Kuma in South Africa, who was trained in the United States and then went back to South Africa, where he was a leader in the ANC in the 1940s and called for a universal healthcare system, among other things, as part of the ANC's platform. So some examples of how the social determinants of health have affected health outcomes in the more recent past include a study by Eric Kleinenberg in Chicago. And he studied a heat wave in Chicago. And he thought that many of the deaths from the heat wave were not just due to the heat itself that was killing elderly and vulnerable people who didn't have air conditioning. He thought that they also had to do with the abandonment of these populations by things like a law that took money from social services, the kinds of social workers who would go out and check on vulnerable people during things like a heat wave, and gave it instead to the police. So these things he thought might have had to do with the deaths from the heat wave. It wasn't just due to the heat itself. It was due to public policy choices that had been made in the years and decades that preceded it. Another study by David Stuckler, Lawrence King, and Martin McKee looked at death rates in the former Soviet Union in the late 1990s and showed that adult male mortality rates skyrocketed. They went way up in the years that followed the end of the Soviet Union. So the green here is Russia, the adult mortality rates among working age adults. And then the red line is Belarus. And you'll see that in Russia and Belarus, in the years following 1989, when the Soviet Union collapsed and many state-owned enterprises were privatized, and many people as a result lost their jobs, you saw a huge rise in mortality rates. So, there was no COVID outbreak in 1990 in Russia and Belarus. There were other causes of death. Many of them linked, these authors thought, to this wave of privatization, this massive transformation in society. So again, we're looking at the social determinants of health, and when we do that, we want to look not only at the biological and behavioral causes, but beyond that to the societal and structural causes. A final note, though, when we do this, we don't want to focus on societal and structural causes to the extent that we forget that there are medical interventions that can be done, even in settings of societal want. So, a cautionary tale is that in 1980, a famous doctor and public health professional, Dr. Walsh McDermott, worried that our medical technology has little to offer infants in a sanitarily unprotected home environment, right? He was worried particularly about diarrheal diseases. And he says that the pneumonia-diarrhea complex in infants largely disappeared from our society without the use of today's technology, but in a setting of widespread economic uplift. So he's talking about the United States. He's saying that diarrhea is gone when you haven't used any technology to do it. We don't see kids dying from diarrhea anymore, to a large extent. Whereas in poor countries, people are dying of diarrheal diseases by the millions. Children are dying. So he thought that we just have to wait for a sanitary revolution for diarrheal disease to go down. However, shortly after he made this statement, diarrheal deaths began to plummet. They began to go down very quickly. And part of the reason, a huge part of the reason for that, was oral rehydration salts, right? And many of you have seen these packets. It's essentially salt and sugar that you mix with water and give to a child who's suffering from a diarrheal disease to keep them hydrated, to prevent them from dying. And it has saved millions of lives, tens of millions of lives, over the last 30, 40 years. So that's just one example. Many public health interventions, many medical interventions have saved lives, even in settings where poverty continues. So AIDS-related causes of death in sub-Saharan Africa fell 32% between 2005 and 2011. Deaths from malaria in Africa fell 49% between 2000 and 2012. Deaths from TB fell 45% between 1990 and 2012. Right, and this led some economists like Michael Kramer to say modern medical technologies allow tremendous improvements in health, even at low income levels. So when we talk about the biosocial, right, we want to focus on social, but we don't want to forget about biological, right? You guys are training to be doctors. And part of the reason we focus on those biological technologies is because they do save lives. They do make a tremendous difference. They do alleviate suffering, even in settings, maybe especially in settings of poverty. So the biosocial is just that. We want to see the biological and the social as linked and as both important. So thank you so much for taking the time, and I'm really looking forward to talking with you again.